intermittent normal calcium level. I touched upon this earlier. The caveat of primary hyperparathyroidism is that one of the parathyroid glands has lost its regulatory ability. Not all four. It's not hyperplasia. Don't think hyperplasia. Think adenomas. Think tumors. The variability of calcium levels is the norm in primary hyperparathyroidism. You and I don't have variability. You and I are living in the nines. Your patients with parathyroid disease have variability. Variability of 0.8 is typical. Can be as much as 1.5. And as I touched on earlier, 75% of patients that we operate on take out a parathyroid tumor, not operating on them for no reason. Take out a parathyroid tumor, fix their labs. 75, 3/4 of them had a normal lab. So if you got a patient who you think's got parathyroid disease, you check their labs, it went down to 9.7. Doesn't matter. They still got a parathyroid tumor. Some of you are nodding your heads, you know that. What we've learned is consulting on order of 3,000 patients with high calcium levels per year. Adults live with calciums in the nines. Everybody in here, check your labs, you're in the nines. Most of us live between 9.4 and 9.8. Normal parathyroid function means little variability. I checked mine once a month for a year just so I could say that I did. Mine was never lower than 9.5, never higher than 9.7. Okay, 9.6, 9.6, 9.6, 9.5, 9.6, 9.6, 9.7. No variability. My PTH never was lower than 35, never was higher than 39. 36, 35, 36, 37, 39, 35. It's the same thing, okay? My vitamin D is perfect because I live in Florida. We're going to talk about vitamin D in just a minute. Wait till you see this. You think you don't like me now? Wait till you see the vitamin D data. Adults with calcium levels persistently above 10 means a parathyroid tumor is present unless the PTH is less than 25. Okay? How do I know that? Because I'm going to invite you later. I'm going to invite you to my operating room so we can look at this. Okay? So teens and young adults have calcium levels in the mid-10s. I have two teenagers in my family. Both of them have calcium levels between 9.9 and 10.4. Teenagers, young adults, if we get sent a patient who's got calcium levels in a 10, 10.2, 10.4, and they're less than 25, 26 years of age, we get very nervous about that. Those patients, we don't want to operate on somebody who's got calcium levels in the 10s or they're in their 20s, in the 10s and the 20s, if you follow me. And remember, we noticed earlier that young people with parathyroid disease do not have subtle parathyroid disease, okay? However, the rest of us in this room, and once you're over 30 years of age, especially over 40, we don't live in the 10s. Adults live in the 9s or the 10s, okay? All of you in here, you're living in the 9s. If you're living in the 10s, see me afterwards, I'll give you my business card, we'll take out your tumor. Confusionary number 3, all right? Let's look at this. Here's the year, 2001, 2003. These are actual patients, okay? 2001, 2000, all the way to 2010. Patient A, patient B. We're going to say, who has the most severe disease? Patient A, 10.5, 10.2, 10.3, 10, 10.9, 10.5, 10.6. Patient B, 9.5, 9.4, 9.3, 11.5, 13.2. All right? So here's what I know from our practice. We're going to get a phone call about this guy because some endocrinologist somewhere is going to say, I got a patient, he's got severe calcium, he's got a real bad problem, he's got severe hyperparathyroidism, needs to get fixed, okay? I'm here to tell you, and what Doug was trying to tell you before, this is the patient with severe hyperparathyroidism. This is the patient who's on 2 antihypertensive, who's on Prilosec, who's on Coumadin because they got AFib. This is the patient who's on Wellbutrin. This is the patient who's developing breast cancer. This is the one who's got 1.8 times chance of dying of breast cancer. This is the patient who's got 2.9 times the chance of dying of prostate cancer. This is the patient who's got severe hyperparathyroidism. This guy has a kidney stone, ain't no big deal. They both need to be fixed. But what I want to tell you, though, is it's the duration, not the elevation. Okay? Who's got the severe parathyroid disease? It's the guy who's had it for 10 years, not the one who just got it by had a kidney stone. Those don't excite us very much. Confusion area number 4, negative localizing study. 92% of endocrinologists say in a localizing study prior to referral to our clinic. Okay? Essentially, none of these help us. Thank you very much. Most are poorly performed. We review about 4,500 to 4,600 sestamibi scans per year. We grade them. We look at them. We grade them. Of course, we bill for reading them. But we look at all these scans, okay? Sometimes they get us some information. But as a general, most are poorly performed. Even the ones that are well performed, oftentimes they're not read correctly. Most confuse the doctor and the patient. We never use the data obtained in an outside sestamibi scan, okay? So I know most of you in this group have got a letter from us that says, by the way, thanks for referral. However, we don't use the scans. Don't get them if you're going to send them. Negative sestamibi scans. Negative scans comprise 82% sent to us. Findings at surgery are identical to those who have a positive scan. Thus, scans have no bearing on the disease present. A negative scan does not mean hyperplasia. I'm going to be harping on this about 100 times here. Okay? If somebody's got a negative scan, they are just as likely to have an adenoma, or two, as somebody who has a positive scan. Is just as likely to have a second adenoma as somebody with a negative scan. Okay? There's no difference in the disease found in somebody with a positive scan and negative scan. Negative scans delay therapy. Delay surgical therapy referral by 2.8 years. Your colleagues, not you, because you guys are smarter than everybody else. We've established that earlier. You guys are better than the rest of the United States. In the rest of the United States, in our database, a negative scan delays surgical referral by 2.8 years. Less than that in the United States, less than that in Florida. You guys are better than your peers. Again, it's highly statistically average. I mean, highly statistically significant. But the negative scan delays surgical therapy. The disease is the same. And it goes back to what Doug says earlier. The NIH criteria says don't get a scan. That's the one NIH criteria you guys all break. 73% of patients sent to us have at least one ultrasound. Okay, we're going to talk about ultrasounds. 83% are negative for parathyroid localization. 89% have some sort of wrong information. So we have a prospective cohort study that's in press and co-authored between us and Jack Baskin helped us out with some of the review of this data. 5,000 consecutive patients, there's a prospective study, 5,000 patients who had at least one ultrasound, and a cohort simultaneously operated on prospective study, cohort 1,600 who had no ultrasound, that was the control. All right, let's look at that data, because this is pretty cool. We looked at endocrinologists doing the ultrasound versus the radiology center. In other words, they came to your office, did you do the ultrasound yourself, or did you give them a prescription they sent out and they got the ultrasound done at some radiology center? The endocrinologist did the ultrasound in their office, correctly located a tumor 78% of the time. They found solitary adenomas, but radiology centers, you gave them a prescription for it, only 18% of the time, 19% of the time, highly significantly different. False positive rates were also very different depending on who got it. False positive lymph nodes or thyroid nodules were read as parathyroid tumors. 1.8% of endocrinologists, you guys don't do that. You know the difference between a lymph node and a parathyroid very, very well. Your radiology cohorts don't do it. And as you know, the radiologist's not doing it. They got a tech doing it, and the radiologist is reading it sometimes later. For single adenoma, sensitivity, specificity. Sensitivity, 79% for the endocrinologist, 94% specificity versus 1949. So you find it 79% of the time, a single adenoma. You're not so good at doubles. Single adenomas, you find it 80% of the time, and if you do find it, you're right. Okay, sensitivity, specificity. Radiology, if you give them a prescription for it, sensitivity 19%, specificity, they're wrong half the time. Multiple gland disease misdiagnosed, as you can imagine. It's harder for us in the operating room. It's harder for you guys not in the operating room. Multiple gland disease is misdiagnosed more commonly, but endocrinologists are still 3 times more accurate in sensitivity and specificity in diagnosing multi-gland disease than your radiology center counterparts. So again, this is our prospective study of 5,000 endos versus radiologists. Of the 1,200 endocrinologists taking part in the preoperative workup of these, actually it's 6,000 some odd patients, in this study, only 21%, only 21 or 1.7% of these endocrinologists performed the ultrasound in their office. The remainder order the scan, which is performed in a radiology center. In other words, there aren't many of you who are doing ultrasound in your office, okay? Because only 21 out of this 5,000, only 21 different endocrinologists sent us a patient who did the ultrasound in their office, okay? The vast majority of you aren't doing ultrasounds. And we have the numbers. I mean, Jack Baskin and some of the others who are working with ACE and training training the ultrasounds for ACE. We know there's a very small percentage of total ACE numbers who have taken the ACE course, and an even smaller number who've actually taken the test and become certified ultrasonographers in the office. But as you see, it's a very small percentage of you that are actually doing it. Ultrasound findings had no bearing on the findings of parathyroid pathology and surgery or the number of parathyroid glands removed. A negative ultrasound at radiology center delayed surgical referral by 2.1 years. My best piece, I love these last two pieces, okay? A negative ultrasound at a radiology center delayed surgical referral by 2.1 years. However, a negative ultrasound performed by an endocrinologist who did it in their office, no delay. In what we found there is, if the endocrinologist is doing the ultrasound in their office, all right, they're ultrasounding thyroids and parathyroids frequently, they therefore do enough thyroid parathyroid ultrasound that they see enough of these patients that they know not to rely on ultrasound for surgical referrals. The endocrinologists across the United States who are not doing it in their office get a negative ultrasound, oftentimes, albeit in combination with a negative sestamibi scan, but as an independent variable, a negative ultrasound delays surgical referral by 2.1 years, and that patient ends up, we don't know where the tumor is, let's come back in 6 months, we'll check your labs again, and we'll do something else. Or they'll see them again in a year, and we'll do an ultrasound in a year, and eventually they'll find something, or just end up giving up and refer them. But it's very interesting data. So bottom line, preoperative ultrasound, in our opinion, if you don't do it, don't order it. Okay? If you do it in your office, it's great data. We'd love to have the data. Please share it with us. But if you don't do it, remember, the data you're going to get, it's the old garbage in, garbage out. You give somebody a script for an ultrasound, it's not going to be very good data as far as parathyroids go. You may find some ultrasound. I understand you're all thinking, what about the thyroid? We're doing it because of the thyroid. What about the thyroid nodule? We're going to get an FNA of the thyroid nodule before you operate, so we know they have parathyroid cancer. So they don't have thyroid cancer. Yeah, I know, I get it. But as far as localizing for parathyroids, it's not going to help you, and it's going to delay your therapy. It's going to just waste your time. Careful.